All right. Good afternoon. Good morning, everyone. This is Jean-Luc Neptune. I'd like to thank you all for joining us today for a panel discussion about the future of primary care. I greatly appreciate the invite from Matt, Matthew, and Jess, and I'm looking forward to a great discussion today. I'm particularly excited to talk about primary care as a physician trained in internal medicine myself, and someone who really believes passionately that the richest, most powerful country in the world has to do better in delivering healthcare to all our citizens. So I'm looking forward to this discussion today and all the many great things that we'll learn about primary care. Now, primary care is a term that we kick around a lot. I think people are very familiar using that term, but I think it may mean different things to different people. You know, what is primary care anyway? And in doing some of the research in the lead up to this panel, I saw a couple of different concepts, including Scott's interesting notion of primary health. So maybe what we can do is get everybody a chance to start here and talk a little bit about what they think primary care is. And since, Scott, I shouted you out about primary health, why don't you lead?
Sure. Appreciate it, JL. So we had the same challenge that you're describing as primary care means a lot of different things to different people. And so because we practice in a multidisciplinary team setting, we felt that primary care seemed to focus a little bit too much on the physician and maybe the nurse. And what we really felt was that a combined team is what really delivers the best outcomes. So when we include now mental health, physical therapy, health coaching, fitness, care navigation, those set of services, those other disciplines should be a part of this overall view. We also felt that health is more descriptive of what we're going for than care, which is often medicalized. We want it to have a relationship. We want people to think about health beyond just physical health, but, financial health and other types of health that are really important for that whole person view. So it was our attempt to try to solve the problem you're identifying. So primary health is meant to describe that broad, team-oriented view of health.
All right, sounds good. And, I hear the term holistic either said explicitly or embedded in what you're saying. Robin, I know that, this holistic concept is important to you. So what does primary care mean at Parsley?
For us, it's similar, I think, to a lot of the folks on the panel here, where we needed to broaden the description of primary care and really define it a little bit better, especially in an era where 90% of our illness is chronic illness that people are living with for years, if not decades. And yet our primary care system is trying to do too many jobs, I think, as a physician, and what I've seen in my training and in my experience. It's trying to do urgent care, and it's trying to do triage, and it's trying to do medication management and referral management, and also treat some of these chronic illnesses. And so for us at Parsley, holistic means two things. One, it's a longitudinal relationship where we get to know you over time and really hold that partnership with the patient. And two, it's about bringing the core drivers of most of today's top conditions, the ones that are most common and most costly, the cardiometabolic illnesses, the autoimmune illnesses, the GI, the behavioral health. All of those things are largely treatable and often reversible if you address nutrition, mental health, lifestyle change, movement, environment on the prescription pad next to prescription drugs. And yet in my training at some top institutions that I know you and I share, JL, we did not learn how to prescribe beyond prescription drugs. And prescription drugs are a key piece of this, but so are nutrition, mental health, lifestyle change, fitness, and experience, as well as a long-term relationship. Because as I said to start, these conditions are not things that hit you on the head when you walk out your front door, largely. Some of them are, but mostly they're things we're living our way into. And so we had to redefine at Parsley primary care as a service that would really address the true needs of today's population.
Okay, sounds good. And Rushika, one of the things that I was really struck by in my research into Iora is your heavy focus on humanity, right? Which I think is a very important concept. As somebody who was a liberal arts undergrad who went to Columbia PNS, where a lot of these concepts were focused on, I was really struck by humanity and how the core to the Iora branding. So tell me a little bit about primary care at Iora and as it relates to humanity.
Yeah, so JL, I think so. None of this is new, right? We all think what we're doing is really innovative. Barbara Starfield, decades and decades ago, really was what was kind of a godmother of primary care. Talk about the 4 C's of what good primary care is. It's first contact, continuity, comprehensiveness, and coordination. Right. So this is what primary care ought to be. I think, unfortunately, the execution of primary care in the US sort of went away from that and it became episodic, transactional, et cetera. Right. So I completely agree with Scott. This needs to be beyond medicalizing things. This has to be about actually addressing people's whole life. What we often say at Iora is we need to help people improve their life. That will help them improve their health. That will address healthcare utilization, and then as a business, we'll capture some of that value that gets created. So we start with our motto and tagline really is about restoring humanity to healthcare. We have turned primary care in this country, by and large, into a series of transactions: document, code, bill, next. The doctors feel like they're hamsters on a wheel. The patients feel like they're widgets online, and that's why I think we, like everyone else on this call, has realized we have to start over, and we just need to build a new model that's based on relationship and not transactions. As Robin very correctly pointed out, the bulk of illness is chronic disease. Last I checked, transactions don't help cure disease. The thing that helps cure it is actually relationship and engagement. And that is about restoring the humanity. And that's why we felt like we've had to, I think, completely come up with a different consumer experience. And that's the root of then a different clinical model, which then changes trajectory.
Got it. All right. And Tim, as our only MD on the call today, I'd love to get your perspective on primary care, but we'll give you an honorary doctorate. We'll call you Dr. Tim Barry for today. But it'd be great to get your perspective because I always feel like as a physician, having gone through this process, the training process, I feel heavily programmed. And I've spent like 20 years sort of getting rid of my program so that I could think about Medicare or medicine in different ways. But you didn't go through that training. So I'm interested in getting your perspective as a non-physician, except for today, of course, on what you think primary care.
Well, thank you. I'd love to practice on any of your licenses if you give me a chance to. So what I would tell you is that I had the benefit of looking at it a little bit from the outside in as opposed to the inside out. And so I had the chance of looking at it from a consumer lens and also from an economic standpoint. And the underlying issue, I think, is that everything that everyone has described so far is I think, spot on. I think every innovative model of primary care that's out there right now is evolving to more team-based care, to more coordination, is sort of driving better data and analytics, trying to be more proactive, more available to patients 24/7, and meeting them where they are, right? And so all of that, I think, is great. I think the fundamental root issue is that we've not invested in primary care to the way that we need to in this country. And again, to Rushika's point, there's more than enough research out there that reinforces this point. But I initially got into healthcare by working at a health plan, and I was amazed, frankly, at what I saw. I'll never forget to this day my first meeting. Sitting around with a bunch of people in a health plan talking about a congestive heart failure disease management program. And the first thing that kind of caught my attention is that there was 20 people in the room all discussing the economics and the nature of where the call center will be, et cetera, et cetera. And no one person thought, well, gosh, what's the role of the physician in this model? What's the role of the primary care doctor, right? And so sadly, I think that the rest of the healthcare system has largely failed primary care. And I think what we're witnessing by the growth and success of Scott and Robin and Rushika's model and many others is that there's an awakening to a level of investment that we have to make in people, process, and technology into primary care. And that when we do that, we can deliver exceptional results. And I think that's one of the fundamental elements that's so different, and why I think this movement is frankly so much different than prior movements 20, 30 years ago.
Got it. All right. Interesting. And I think that's an interesting opportunity for me to drop my first bomb. And I like to drop bombs in these discussions. I will make the argument that nobody cares about primary care. In other words, like I think that most people, let's say less than 50 years old, who don't have any medical problems, don't really care about having a relationship with a physician. They like the transactional model, right? They don't need somebody to take care of them. Maybe when you get to be a geezer my age, you sort of, middle-aged person, all right, I have to get a colonoscopy, I have to get a derm check, I have to get my annual physical. But, I'll make the argument that a lot of people don't care about primary care. And if individuals don't care about primary care, who is going to care about primary care enough to make it a growing specialty practice, a growing service? So I'll drop that bomb and see who wants to field that one.
I'll start.
Yeah. Good.
So I don't think you're wrong, but I think the problem is most people have not seen what good primary care is. The stuff they're getting currently with their crappy doctor and fee-for-service and churning the wheel is not what we think primary care is. So we had a practice, we've been serving older, sicker people. And then we had a first practice where we served sort of young, healthier people up at Dartmouth Health Connect. And we were wondering, wow, do people really want health coaches? They want this integrated behavioral health. So they want this sort of emailing and texting and group visits and all that. And turns out they do once they actually get it. Yeah. All of us, every one of us can make our health better. We all can feel better. And I think this relationship is something virtually everyone likes. Now, they don't know that when they come in. We often say they come for the doctor because they think that's what they need as a doctor. What they stay for is a health coach and all the other things because they said, wow, I can actually make it better. So I don't disagree with you that in general, people don't think they want this because they've never seen it before. I think once they see and experience it, it's a different story.
Okay. Anybody want to agree, support, dispute?
So I agree with Rushika. I mean, I'd probably say it a little bit differently and say that I completely disagree with you, JL, and that I think that everyone's looking for solutions to their healthcare issues, regardless of how big or small they may be. And so the question is, who's filling that void? And I think that the failures of our healthcare system for the last several decades have taught people, both young and old, to go look for other solutions to try to navigate the healthcare system on their own. I think when they find a caring individual who demonstrates support and love and affection and 24/7 capability and service and is willing to see them in the hospital or see them in the home or just be accessible to answer the simple, silly questions that they might have. I think that's what we are all redefining as what primary care is. And so it's sort of like, to me, the question you're asking is analogous to how do people feel about Sears 50 years ago, right? And so the answer is the old model is a dying model. And I think it's a model that if other organizations don't step up to the kind of care that organizations like Robin and Scott and Rushika and Village perform, I think those organizations will fall to the wayside.
Okay, well, let me reframe the question. So I agree. Again, I was dropping a bomb before. I agree that people who get a great healthcare experience can appreciate it once they've had it. And Rushika, what you described to some extent is what I call like the doctor's family experience. So my sister and my wife experience healthcare in a very different way, right? My wife will ask me 10 different medical questions in a day that I will answer. My sister will send me texts at random times, like will show me a picture of like a tick bite or something. And they get all kinds of navigational support. They get the services that you guys are describing. So I agree that if you have a family, a doctor of the family, you're getting that that kind of service, and a service like you guys provide can deliver those things. The question that I have is financially, who cares, right? Because does it really move the needle, Rushika, to the service that you describe? Can we bend the healthcare cost curve by providing those level of services, or is it just incremental cost on an already outrageously expensive system? So I will give Scott and Robin a chance to answer that question.
Robin, why don't you go ahead? I know you were trying to jump in.
I mean, that sort of dovetailing on that and to your earlier question, I actually agree with you, JL. And I think that the average person thinks that primary care is urgent care. And we've conflated those two things. And so language is really important because our population, while it ranges from age 2 to 90 years old, is largely people in their 30s, 40s, and 50s. And they don't value Parsley because we are primary care, because in their minds, that's treating your sinus infection or refilling your blood pressure script, or maybe an annual physical, which, in many cases is no longer even paid for because the data on it shows it's not terribly valuable. But what they are coming to us for, and what largely women across the country are coming to us for, is feeling like crap. These people aren't feeling well. And 60% of American adults have a diagnosed chronic condition. Tens of millions more are living with chronic illness that they have and they don't know about yet. And women are often living with multiple comorbidities, and they are suffering. They are often suffering for 7 years before they come to Parsley. 1 in 5 of them has been dismissed by their healthcare provider or in some sort of healthcare setting. And they're ping-ponging between a primary care doctor, episodic, transactional, as Rushika says, specialists. The average person with a chronic illness has seen 2 in the past 6 months, and Dr. Google. And they're trying to figure it out, and they're burned out on all of it, and they're spending money, and they're hitting walls with weird wellness solutions and sort of the wacky consumer world that's out there. And so for those people, to answer the second part of your question, there is real value and there's real outcomes to be had, because I think the misnomer that we have is that people who just need primary care are healthy and people who need something else are sick. And the reality is the majority of American adults, hundreds of millions of people, are living in a gray area in between, but they actually are sick and they don't feel well. And they're willing to spend money. In fact, they are spending money out of their personal pockets, because now 50% of plans are high deductible plans. They're spending out of their pockets trying to feel better, but not because they see the value prop of a primary care doctor who knows them, but they do see the value prop, at least in our patient population, of not feeling bloated all the time, or having migraines, or being able to get pregnant without IVF, or dealing with their autoimmune condition without 3 specialty drugs. That is what's different. And that's where I think you can have real true cost savings, real true impact, and then that's how you pay for it.
Okay. And I can believe that on an individual level, particularly people who are going to many providers, there is definitely a value argument to be made by going to one place that can sort of bring this all under control. But Scott, I mean, how about from an employer perspective or the payer perspective? Like, do they care about primary care?
Yeah, so let me answer this way. I'll share a personal experience, but first of all, I agree with what Tim said. You don't see like Sears healthcare, right? I mean, that's kind of the experience we're all getting, like old school, kind of old generation. And you hit on the point, which I hope we make during this panel. You have to have different business models to make new care models actually work. The old traditional way of paying for stuff is going to get you the old traditional result. And so you got to have new models of payment and so forth. So I'll give you the example. So I have a traditional physician. I went in to see him. I'm generally healthy. He went through his whole little rip-de-doo of a physical, which Robin, I agree with. I don't think they're very useful. And at the end of my visit with him, after about 30 minutes, which was generous because I'm a doctor and he gave me a little courtesy there, he said, "Hey, Scott, great. There's nothing to do for you." And I'm like, what? There's nothing to do for me? Like, I'm generally healthy, but hey, I want to eat better. I want to sleep better. I want to manage, all the stress and challenges that I have. Like, you have nothing to offer me. And he's right. In the traditional model, there is nothing to offer me. But if you look at all the models that we have, coaches, we have programs, classes, other things to engage in, because that engagement is important, because when you actually really need something, you got to have those relationships in place. And that, I think, is the best example I often give, which is just like, there is nothing to do for me in that old world, and I need a new world to do this. I think the reason why Parsley exists is because all those patients couldn't find what they needed. Why is Roe and Hims and these other guys, why are they so wildly successful? Because they help consumers address specific needs. And what I love about what they're doing, they start with these kind of wacky, a little bit more like, ED drugs, refills, to now like, hey, we're getting into real legit stuff. And I think what looks, technology is always the same. It looks like a toy at the beginning, and then it becomes something wildly impactful. And what we've all been waiting for and pushing on so hard is to get different financial models to power and pay for the care models while the data catches up and I can prove and show that this is the best way to go. And hey, if I'm a young, healthy, getting enrolled in programs and being thoughtful and investing in my most important asset, my health right now, is going to pay incredible dividends. And then also, if you're very sick, your asset you need to have asset management. Like, you need to have someone who's really wrapping their arms around you, driving that. And I think Robin called that an important point. when we say healthcare, we're describing like multiple things at once. Like, is this just urgent needs? Is it for the well? Is it really sick for, so we have to kind of parse that out. And I think, hopefully we'll have a chance to do that today. But I just want to highlight that I do think people really care about this as they get it. If you're a payer and you're watching the bill go up 10 to 15% a year, you're going to, at some point, you're going to be sick of watching that happen. And all I'm seeing, from an employer perspective, they are now becoming what we call healthcare activists. This is the only part of their supply chain that goes up 15% a year, and everyone just sits around, I guess we'll just write the check again. And they're done with that. So we're starting to see a lot of people try to figure this out. Why is this so hard? Why doesn't this work? Let's go to root cause first principles and really starting to dig in. And that's why I think some of these models that you're seeing on this panel represented by this, really starting to come to the forelight. And I do think they care, JL. I do think you're going to see that. But I do think we need more evidence. We need more, examples of how this works, and we need more data, to prove it.
Maybe I'll make 2 points to add on. So one is, I think it's unfair and not the right thing to say that the only way we should do better care models is if it lowers costs, right? The point of the healthcare system is not to lower costs. The point of the healthcare system is to make us healthy, right? And everything else in this economy, if it provides value, we should pay for it. So if I had a drug, if I had a pill that I could give people that would make you feel better and that would lower your A1C and lower your blood pressure, I get paid a fortune for it. And we don't expect those things to save money. They actually improve outcomes. So I think holding primary care to a standard of it has to save money is just unfair because we don't hold little pills to that. That said, I think all of us on this call, and certainly many of us call, have proven, we've been around a long time, that doing better primary care makes huge impacts on lowering downstream spend, particularly for sicker people, right? And I play a little game with myself. I still attend on the ward service at Mass General, and I walk around the ER, and I say, what percentage of these people could not be in the ER if we actually gave them the right sort of relationship-based primary care? By the way, the answer is about half. I walk around the inpatient.
I believe that.
What percent of the people would not be sitting in an inpatient bed if we actually did good primary care? And by the way, we and other people have shown 40, 50% drops in hospitalizations, ER visits, procedures that people simply don't need, right? They neither want nor need it, actually, if they know the facts. So again, I think primary care can dramatically lower total healthcare spending. So the payers, whoever's on the hook for that, is certainly interested. But in some ways, it's almost an unfair question. If it actually just makes people feel healthier and improves outcomes, that should be good enough.
I can agree with that completely. Now, one thing I'll comment on is I'm old enough to remember the 80s and the 90s. I graduated from college in 92. And I remember that time, the primary care provider was going to become the king of the healthcare delivery network. And HMOs were going to send everybody to the primary care provider. The primary care provider was going to control everything, reduce costs, provide people with a great experience. And obviously, that experiment failed over a number of years as people chafed at lack of control, lack of choice, et cetera. And I guess my question is, as we think about this new version, this new crop of primary care, have we maybe solved that problem? Have we come to a point where now people have a lot of choices? As Americans, we expect abundance, right? We expect to be able to do what we want and not to be constrained in how we choose to get our healthcare, let's say. So is maybe the solution that you guys are all developing in your own way really the answer to what we should have done in the 1980s and 90s, instead of limiting choice and narrowing tightly the kinds of services that people could access, give them a bunch of services that hopefully at the end of the day could produce high quality outcomes, lower costs, and a greater patient experience. And I'll throw that out to anybody who wants to answer it.
Yeah, I'm happy to start. From as sort of a student of this, JL, I would tell you that the failings of a few decades ago were really a function of first and foremost provider organizations believing that they should adopt the clumsy utilization management tools that health plans had as the basis for how to manage cost. Right. So that was sort of mistake number one that kind of came into play. The second is we were living with asymmetry of information. So you had provider organizations who really, in many cases, EMR adoption hadn't been all that significant. So it was all paper-based care delivery. So you had actual data from the lens of the plan, and that those organizations who were passing on risk. and you had virtually no data and no scale or capability around analytics and the care delivery lens. We also had a dearth of technology, partly driven by the lack of EMRs, but there was really no connectivity and no way to look at the totality of a population. And so you have all this sort of confluence of all these factors that really sort of led to great promise. And at the end of the day, we had organizations who also were contracting with payers where the level of quality was not measured. So to the point that everyone I think here has made, taking costs out of the system is actually really easy, right? Anyone here could deny access to all kinds of care and costs would just plummet. The reality is that we actually have, as a healthcare system, we have gotten smarter. So everyone here contracts that, at least for us, if we don't improve quality of care, even if we drive down hospitalizations and we drive down ER visits, et cetera, if we're not driving improvements in quality, we don't generate material margin. So there's a reality that we have to incorporate quality. We have to incorporate patient experience. I mean, thankfully, as much as the government can at times be challenging, they're actually pushing the industry so that you look at CAP surveys. CAP surveys are a step towards a better comprehensive patient experience. And so all these things, I think, have gotten us a lot smarter. And so that the organizations who are doing this and doing this well have found a way to really create this proactive, high touch, wonderful feeling for the patient, but I've also figured out a way to use their size and scale to actually work with non-aligned fee-for-service driven providers to actually have them do things differently than they would naturally do to help drive better outcomes.
What happened in the 80s was a lot of what I call roll-up, that people just took primary care docs and they didn't change what they do. And I think Einstein said, if you don't change what you do, expecting different results, it's a sign of insanity. So I think what we've all done is we start with a different care model, right? If you say we should take the same old care model and just put more people into it and expect different results, right? So we start with actual care redesign. And the second piece, I think, is exactly your point. One of the mistakes we made in the 80s was force people to do things. That's not a very good way to do it. So we are not gatekeepers. As you said, we're not using the health plan playbook of deny. We are concierges. We're going to help you and be on your side of the table to help you navigate the system. There's a subtle but very important difference there. And then we also never want to force people to be our member, right? So the second you don't like what we do, you can walk, and you should walk. And we lose our revenue stream associated with you, right? So we have to earn that every single day. And I think and we've got the systems. I think Tim's point that we have systems to track and measure quality. We all monitor and measure it. If there are docs who are underutilizing, we're going to get on them as much as people are overutilizing, right? So I think I can imagine how they did in the 80s. When we started working with Humana, even 10 years ago, they would mail us boxes of binders. That's how they gave the data. And we would literally be opening the binders with highlighters and clipping pages and mailing it to people. It was ridiculous, right? And now that we have APIs and real data systems and analytics, it's just and we can risk adjust. It's so much better. So I think we're in a much better position now than we were back then.
Got it. And Tim, you brought up a point that I feel strongly about. I very much question whether primary care should be funded in a fee-for-service model, right? Paying doctors, $17 for code ABC, then paying them $23 for code, XYZ. I just don't think that it doesn't provide providers the flexibility they need. So for instance, I run a company called Central Modern Recovery. We take care of people who are dealing with addiction. They have very high chronicity. And what we do is we give them one price for the month, and however they want to interact with us is the way they interact with us. You want to text us 10 times a day because you're feeling cravings? We're ready for that, right? If you need somebody to go to your house, we can do that. Now, obviously, addiction is different from primary care in some ways, although similar in other ways. But my question is fee for service, should we be getting rid of that model altogether for primary care? I mean, Robin has a subscription model. What do you think about the way we pay for this?
100%. To be honest, we're very active in Washington, trying to accelerate a movement towards more and more risk. I mean, at the end of the day, it's we all know that with the right level of quality in place and establishing the right measures that have to be achieved from a clinical standpoint, that we in fact can drive better outcomes, better patient experience, and reduce the cost of care. And so, like from our view, we'd love to see it mandated, and we'd love to see the government and the employers and health plans step up and take a bigger role and really drive this change. It's interesting if you think about during the span of COVID. For those of us who've lived in a risk-bearing model, we were laser focused on every single high-risk patient. What can we do with them? How do we make sure that just because COVID's around, their COPD and CHF still exists? How do we take care of them in the most effective way? And so our conversations in our strategy room, in our boardroom, were how do we take care of our most vulnerable patients and take care of all our population of patients? The conversation in the strategy room in the health system down the road was, how do we entice demand? At what point in time can we bring demand back, right? I mean, think about that. As a healthcare system, largely nonprofit health systems, sitting there trying to figure out, how do I reinvigorate demand? Yeah. I'm sorry, that's bullshit. I mean, the reality is we as a society need to be doing a better job of taking care of everybody. And I think a risk-driven model is the best way to go.
Yeah, I got to tag in on this too. I mean, Rushika called out something that I really feel strongly about. Like, I think the old model in the 80s, 90s, whatever, was kind of like this compulsion, right? We were compelling people. The choice was kind of taken away. And now you kind of compare that to the kind of the concierge model. What's interesting about that is, architecture's destiny. So now in that you're compelling the patients to do something, but the physicians are also compelled or compulsively chasing these little fee-for-service nuggets, $17 here, $32 here. And, can you imagine going to the, the store, a restaurant and buying, lettuce and a hamburger and buy every constituent part instead of the main thing? And the reason why that's so critical to think about is because when you break it out by all those little constituent parts, then you chase all that versus you serve up the thing. I love Tim's example. We had the same experience during COVID. We're on basically a fixed fee model. And so when COVID happened, first of all, it did nothing for our care model. It didn't matter that people weren't coming in because we were still actively reaching out. But now you're like creatively finding ways to actually solve the problem. Let's reach out, make sure everyone has refills. Let's make sure everyone has transportation. Let's make sure people are getting the care they need despite the inability to come in. No change in the revenue model. We never had to change and do these kind of weird acrobatics that Tim's describing with the health plan. And so I do think if you can change the payment model, I think you can fund and pay for the care models that actually drive the results that we're all trying to talk about. And we just feel passionately about that. And it's not easy, right? It's so easy to put your head down and do fee for service. It's so much harder to kind of bundle these things up, develop a subscription model like Robin has, put these things together in a value-based way like Rushika and Tim have, and that we're trying to do. And I mean, that's challenging. And what's surprising is, the payer doesn't always want to play ball with you when you do that. There's a good game they talk about, but I really feel strongly that if 5% of your book of business is value-based and 95% is fee for service, you can't tell me, that you're a value-based provider. I mean, you're just not. I mean, so like put your money where your mouth is, get into models that put yourself at risk and deliver and create value. And that's how you should capture it. And that's how you should be successful.
I agree with everyone here. The one distinction I think Parsley has, or one of them with everyone here, is that we are direct to consumer. Yep. And that's where our revenue comes from. Although we are increasingly working with health plans and employers, which is an interesting exercise that I'll have to ping all three of you or four of you about later after the call.
Some gray hair to show you. Yeah.
I'm getting there. But quickly. But one of the reasons we started direct to consumer, and we started, we were originally bootstrapped in 2016 and have raised most of our funding and built most of the company since 2018. So that's sort of our period of growth in this era of the consumerization of healthcare, right? Which means a couple of things. One, being really responsive to the individual and what their needs are, and how do you drive value for them versus the system, the employer, the government, the payer. It also means, I think, what we've seen largely lately, which is the growth of some of the companies Scott mentioned earlier, which is that people are willing to pay out of pocket, especially if they have high deductible plans, for convenience, for point solutions, for just getting the thing that they know they need right now. And I think some of these trends are really changing the dynamics of the healthcare system. And from what I'm seeing, forcing some of the powers that be at least to start to pay more attention, to start to think about other types of models, to start to contract with other types of models. But to everyone's point, it's slow going. And in the MA world, what I observe is that even though you're not on fee for service, you're still in a pretty arduous process of sort of coding optimization, from what I understand, which takes you away to some degree from what is ultimately the goal of patient care. And so if we're going to take consumerization of health, which is not just about convenience and point solutions and high touch and a beautiful environment, whether online or offline, but I think ultimately like driving value for the individual who's seeking care, whatever channel they come through, we have to also redefine value. And just as we had to redefine, and all of us have, the care model itself, what is the medicine that we're actually providing, which we've done, we have to also redefine what does it mean to drive health outcomes. And most health outcomes in our system today, and this is where I think we're hitting that rub of fee for service versus value-based, outcomes are largely utilization. And if health outcomes are equivalent to utilization of the system and the goal is to drive down utilization, that is not going to result in true value-based care. We actually internally developed our own patient-reported outcomes measurement that we just published and validated across 9 body domains to actually be able to track symptoms and self-reported improvement in a remote ambulatory population, because the stuff on the market like Promise 10 was inadequate. And we created one, and now it's a real outcomes measurement, which like Stanford is using, which is super exciting. But I think it speaks to what I think the next wave is going to be, which is not just redefining the model, but making sure the model is connected to value, and that value is connected to health, which is what Scott is talking about and Rushika is talking about as well. Everyone here is not just where the money flows in the system, because those two things are still, I think, conflated, which is where you get 95% of the commercial books, which is what we're seeing as we're going to network, still on fee for service, even though there's a lot of conversation about value.
I'll state it maybe stronger than anyone. Fee for service is the wrong way to pay for primary care. I think trying to innovate care models to get better outcomes, fee for service is a waste of time. So I think a lot of what's going on right now is a waste of time. And by the way, fee for service with a true up later, like most of the ACOs, is a waste of time. Right. I think if you think about it, it's awful for payers because it just leads to more stuff happening to people. I think maybe most importantly, it's awful for patients. It leads to episodic care and not relationship-based care. You don't pay for relationships by transaction. I think maybe even more to the point, I think that because of the huge asymmetry of information and power, fee-for-service allows doctors to do things to patients they don't want or need. And I think, I had a doc once call the patient my little ATM. I can just print money off this patient by doing things. I mean, they don't know that you don't need said test or procedure, right? It's if you did some of this stuff in financial services, you'd get your license taken away because you're not acting as a fiduciary. And somehow we allow doctors to allow oncologists to make money off of the chemo they prescribe is completely a conflict of interest, right? And I think it's ridiculous we do it. And then finally, for doctors, I tell doctors, this is about freedom. It's not about risk. Right? It's that we now have the freedom to make the decision, Tim mentioned this, of how to take care of the patient, whether it's an email or a text or a health coach or a home visit or whatever. We don't have to ask the question. And COVID just proved that you cannot take good care of people when you're constrained, right? And I think all of us, during COVID, we didn't miss a beat. Our revenue didn't change one iota. We could do the right thing. We could give people tablets. And what we showed was, we have the hospitalization rate and the death rate from COVID because we were able to do it. And most practices just threw in the towel and just stopped seeing people, or maybe heroically the doctors did it, despite the fact they didn't make any money off of it. So again, I think it's really clear. Fee for service is the wrong way to pay for primary care. We have to stop doing it.
Great. Excellent. And to shift gears a little bit, but build on something we talked about before, this is a conference where the term tech appears in the title of the conference. So we got to talk a little bit about technology. But I have continued to argue since the dawn of the digital health era that technology alone is not the solution, that you need to really reconfigure many things, right? And it's people, process, technology, that framework that we really have to think about. But thinking about the technology, I think that almost all of the technology that doctors have in their offices are designed for one thing, right? Billing, coding, revenue cycle management. And those technologies are impossible to use if you're trying to provide relationship-based care. Again, going back to my situation, if we're dealing with somebody who's trying to get off opioids, we're inducing them on buprenorphine. On their first day of interacting with us, they might text us 10 times in a day. How do you put 10 notes in a way into an EMR without shooting yourself in the head because it's so difficult? So I have continued to, we're a lot earlier than you guys as a company, but we're still very much trying to solve the problem of how do you encode 100 interactions with a patient that in a typical primary care setting might only be 1 or 2 interactions. So I wanted to get your thoughts on this. I think that most technologies that exist now are unredeemable. They can't be used for what we need to use them for. And I think that part of the reason that a lot of you guys are raising 9-figure amounts is because you have to build that technology from scratch. So I'd like to get your thoughts on that.
I'll just throw something out real quick. Don't solve that problem. Just dissolve it. Get rid of it. You'll find that most of us have written our own software because we had to figure out new ways to do stuff. Like, to your point, what even is a visit anymore? What does that even mean? Like, because you're not coming in, but I have all these like micro interactions with you. And so what we realized, and I've talked to Rushika many times over the decades with him about this, is that we just had to build our own software that could engage the patient, continuous relationship, ongoing communication, and then figure out a way to get paid for that, which was not on a billing basis, right? And so I think everything, I like what you said, JL, people, process, technology, and I think it should be in that order. You start with people, a great relationship. You rework workflows to fit to how the patient needs to interact. And then you use technology to enable those things and to extend your physicians, not to replace them. We always say technology is not the shiny object up front. It's the magic that happens in the back that you don't notice. And so that's really, I like that framing, people, process, technology. And I think, all of us in some way or another has probably had to solve that whole chain to create the value for the members. I can tell you, the fact that we built our own purpose-built for our unique population, for how we serve them, has been incredibly helpful. It's enabled us to flex and to move quickly, and it's been part of how we've been successful. So it was a necessary part, but it's not something you see right out of the front. It's just part of how we work.
I would argue that we've moved past software to data.
Yeah.
And the biggest problem I have with the solutions on the market and have for a long time is that the data models don't make any sense for the kind of care that we all largely provide. And so as much as I would love not to have to basically half build an EMR with a whole bunch of other tools surrounding it, the first line in every prescription for a Parsley patient is food. Food is medicine. And we have hyper-specific nutrition protocols that are tailored to different conditions. It's not a like lip service of eat healthy. And that comes before a prescription drug or a referral. But if there's no place in your EMR to prescribe nutrition the way you prescribe a drug, or there's no place to prescribe meditation, which we prescribe 10x more than medication, or there's no place to show that a condition got better. This is the hilarious thing about EMRs and those sort of software models, is there's no way of tracking outcomes over time, because it's so episodic. So when we put somebody's autoimmune disease into remission, there's no way to like track that in the system. And then if you're going to talk about value, or you're going to talk about longitudinal care or relationship-driven care or personalization, you can't do that because the underlying data models aren't there. And then you can't build algorithms or ML because the data is not living in a lake you can use. So I think that a lot of us have built it not just because the software interface sucks for providers and patients, which is true, but it also because we're operating around a different core data set and data model that's both longitudinal and broader. And in our case, because we do a lot of testing, deeper than what the system has said a doctor does. And that is really challenging, but therefore to create the value for the member and then create the value in the business. To your point, JL, you have to raise the money, and we're doubling our engineering and product design teams right now because so much of the work we're doing is around the way that we service care through data and software.
JL, we just made a decision very early on in the sort of life cycle of VillageMD that we wanted to create our own operating system. And we wanted to do that because one of my frustrations is that in the healthcare industry, far too many organizations love to start with the 1 and the 0. And they end up building something which is a great kind of closed loop system, which allows them to optimize what they do in the construct of the things that they control. But part of the reality of being a risk-bearing organization is that you have many other providers who are caring for patients that you're ultimately trying to optimize the experience for. And so that can be imaging, that can be hospital, it can be LTAC, it can be the joint venture that the hospital has with Kindred. The list goes on and on and on. And so the reality is that if you want to be optimized in terms of the level of data that you have to create an open system that allows you to be capturing multiple disparate sources of data at all different times and ensure that it's being optimized in a way that then drives clinical intelligence into the hands of people who can do something different with it. And we also have to recognize that if we're living in the consumerized world that I know Robin, you talked about, or others have talked about, then I have more than just one application on my iPhone. And so we chose to build an operating system that would allow us to both build proprietary applications, but also allow us to partner with other entities who have other interesting applications that either the doctors or the patients find of value to them, and find a way to be capturing all of that data to allow it to ultimately drive our clinical algorithms, to drive our level of intelligence in the way that we interact with people, whether it be on the way that they best prefer to be communicated with, whether it be the way that they want to schedule with us, whether it be whether they want to text with us late at night, or whether they want to see us that next day. And so, I think part of where we're going as a healthcare system is recognizing that the organizations who are out there that have built these sort of closed loop systems really haven't done the system a great service. They may have done great things for their own companies as technology-based companies, but in terms of organizations who are ultimately driving the best outcomes, regardless of where these patients are. Because like when you start caring for a COPD population, and Rushika can tell you this chapter and verse, but if you take an unmanaged population of patients who have COPD, you're looking at 800 admissions plus per 1,000. Right. And that they don't always go to the exact same hospital, and they don't, what happens at discharge doesn't happen the exact same time. And when they get discharged, they spin the kind of wheel of fortune wheel, and they end up discharging to one SNF facility versus another. And so our reality that we live in, if we want to optimize the experience for every single patient that we touch, we can't be just building these closed systems. We have to build an open system and an operating system that allows us to be, interchanging data on a pretty real-time basis.
Let me talk about the implication of what we all agree, and we've all made the decision to invest heavily in technology. And it's because I think we could not do what we do without that, right? But the two big implications. One is if you're a health system and you are using a standard EHR, Epic, Cerner, you pick your poison, you can't get there from here. They are fundamental. Robin pointed, their data models are fundamentally wrong. They're fundamentally built about optimizing transactional medicine. I think you need to take a really hard look at this. We run into this thing where we want to work with a health system. And remember, one said, well, you have to use our blank, I think, the all script system. I'm like, why? Do you like it? No, we hate it. But wouldn't be fair if you got to use a better one. I was like, come on, you can't do this. But the other implication is for small independent primary care, right? So I think this is the question. If you're an independent primary care doc, there's no way you can make the investments that we all in this room on this call have been able to make. And I think, again, I'm a firm believer in independent primary care. I know Tim has got a business model where they continue to work with them, but you've got to be on a different sort of technology platform. Just like you cannot do the care of the future with the current business model, you cannot do the care of the future with the current technology model. It just doesn't work.
Right. Okay, and I think we got about 15 minutes, so I wanted to discuss two more things. I wanted to talk people, and then I wanted to talk a little bit about the future. So just on the people process and technology. So I was trained at a very traditional ivory tower academic medical center at Columbia. My dad was a doctor. And the universe that I grew up in was everybody who is not a doctor is garbage, right? They are basically people who couldn't get into medical school. Okay, that's that, and I am ashamed to say that, but it is the truth. Okay, what I really noticed in all of your descriptions was the importance of what doctors might derisively refer to as paraprofessionals, coaches, advocates, and all these other people who I think are critical. And honestly, in the addiction space, most of the treatment effect comes from people who do not carry MD degrees, and I'm a passionate believer in letting other people provide healthcare, which I think at the end of the day is very threatening to the guild, the modern physicians guild. Okay. So my question to you guys is, and I also want to shout out my friend, Jay Parkinson, who I spoke with a bit ago. And Jay made the point that he thinks there could be a future where the paraprofessionals, coaches, and other people are able to provide care without doctors being involved in the care loops, that the standardized work plans, standardized workflows could provide a very significant percentage of the care. So wanted to get your perspectives on that and whether you think that there's validity to that, or are doctors primal to the survival of healthcare delivery in the future?
Over what time period, JL?
Good question. I mean, let's say the rest of our working careers, let's call that another 10 to 20 years, depending on how old are you.
I'm happy to start off. I think the doctor is absolutely quintessential. I mean, there's just, at least from our perspective, we believe technology will increasingly play a bigger and bigger role. I think doctors that we work with are attracted to the idea of having a care team, and having social workers and pharmacists and other paraprofessionals who are engaged in extending the care beyond the exam room. I mean, I think that's one of the more significant awakenings as we talk to physicians who are out there fighting it out day in, day out to do the best job they can for their patients. They know they're sub-optimizing. And so to the point everyone has made here, there's a level of investment that we make. But at the end of the day, we think that the doctor is still going to be such a critical part. But I think that the role of the doctor is going to fundamentally change, and it's going to change to be less of the superhero and less of the problem solver in every single scenario, and more of maybe coach and mentor to the rest of the care team, as opposed to the superhuman trying to solve every problem.
I think clinically, people who say things like that, we have an investor, Vinod Khosla, who likes to say, I compute with doctors, and he's being provocative. I think there are two reasons. I think one is this human thing, that there's this magic about someone who's a doctor, for better or for worse. And I think we empower our coaches because they meet them with the doctor's arm around them. We take this doctor magic, and then absolutely a huge chunk of this doesn't need to be done. It shouldn't be done by the doctor, but being part of it. The other piece is just understanding biology. So yes, 80% of people who come in with hypertension can be treated really well with step therapy and an algorithm. Start with a hydrochlorothiazide, if not, then escalate. And if they've got diabetes, then put them on an ACE. And we all know how to write these things. The problem is 10% of people don't have essential hypertension. They have something funny going on, a cork of the aorta. They've got by the way, most people don't even know these words I'm saying, and they say these things. But the problem is a small number of people don't behave according to the algorithm. That is the way it is. We know that. And so that's what doctors should be focusing their time on, not on the routine hypertension. It's a waste of our time. But the 10% of people who don't have essential hypertension, or we have to use all these years of training and pathophysiological reasoning to figure out what the hell they have, so we can put them on a different path, right? So the role of the doctor is, I think, to Tim said, supervise the team and build them up, but also in that small number of cases, figure out who those are. And now you need to work on those people.
I think it
and Rushika, by the way, and Rushika, I would just say, just based to build on your example, my father had refractory hypertension for a period of time. They thought it was, ran him through everything, and it turns out he had a brain tumor, and that was the driver of his hypertension. And that's where you really need that higher level of understanding to be able to make that determination. But sorry to interrupt, Robin. Go ahead.
No health coach with an algorithm or a computer will have figured that out. That's what good doctors are for.
Right.
I mean, I think that's a great example, and it comes down to complexity, right? The software is great when the use case is really simple and repeatable, but as soon as there's complexity, that's when it kind of breaks down, and you need the humans, and we just don't have the computing power yet. And I don't know a single human being who isn't complex. And the women that we see day in and day out at Parsley, they're dealing with infertility and anxiety. They're dealing with a thyroid problem that's been misdiagnosed as depression, and yet a boatload of Zoloft is not going to make them undepressed if their TSH is 8. And no one's testing for it. They have autoimmune and migraines. They have food allergies and asthma and eczema and a whole host of other things. And so 80% of our members have 2+ comorbidities. Some of our members, a significant portion, come to us with what I call FLC syndrome, feel like crap. They don't know what they have. And they come because they're tired and foggy and burnt out and gaining weight and exhausted and achy. And they're told that you're just a mom. And as a mom of 2 and in 2 weeks, 3, I can tell you that there's a difference between just being a mom and having an underlying comorbidity that's been misdiagnosed or undiagnosed that I'm struggling with, that's making me feel like crap. And so most people have that complexity. And so I think the role of the doctor is hopefully to not do some of the rote administrative tasks that none of us went to medical school for, but to do what I think someone said earlier, and we talk a lot about at Parsley, which is the investigative journalism of medicine. That's what I call us often, because we're doing the digging to see the whole picture and put the story together. And the story of your health is the story of your life. It started when you were born, whether it was vaginally or C-section, the foods you ate, the traumas you experienced, big T's or little T's, the experiences you had as a teenager and in your 20s, everything that led up to today. And so that's what I think is kind of exciting, hopefully, that all of our fancy data and our software and our awesome payment models will add up to people getting more of that whole picture, whole person care over time that sees you not just as a subset of organs, because that ultimately leads to bad medicine. It also leads to what I think we're all seeing, because we all do holistic whole person care, and to some degree or another, this massive escalation of costs, which I think is starting to be recognized, is when you have a thing for the hypertension and a thing for the blood sugar and a thing for the migraines and a thing for the eczema, every one of those things or solutions has to have a margin to it. And you stop seeing the whole picture, which leads to bad medicine, and you actually are driving up costs. And that's what I hope for people like me, doctors like me, we get to ultimately do that investigative journalism and whole picture medicine, which we got kind of pushed out of by the system.
And congratulations to you, Robin, on your expecting your third. And I also, as a parent of 2, I say, God help you. So
God help me. Glad I'm not having the baby like on this call. It was close, but.
And Scott, any final thoughts about the role of non-physicians in the system?
I'm an athlete, so I'll use an athletic. I just think it's kind of I think in terms of teams, right? So you look at a football team, you have a quarterback, which is historically what we think of as the physician, but no matter how good that quarterback is, if he doesn't have all the other players, playing their roles and contributing, they're not going to be successful. And so I think the game, as it's evolved, has now moved from the quarterback being like the highlight to like, hey, there are other people on this team that can really contribute. And I think we need to, have, with common phrase, but get everyone to the top of their license, because then the physicians doing that last mile 10% that where they can really add the unique value. Certainly, we have the shortage of providers, technology and mid-levels and other providers can really step in and help. But I think there'll always be a role for the physician. Although I think the weighting and emphasis will change over time due to those other factors. I think that's great. I mean, a great team doesn't have 5 Michael Jordans, right? You have a mix of players and talent and capabilities, because I really like what Robin said is we're not addressing a disease. We're addressing someone's life. We need to build a relationship, and there's lots of people to bring to bear to support and improve that. And, again, as the whole part of this panel, we're excited to see there's starting to be some recognition of models that can now pay for this, technology that supports it, and obviously great people who are coming together to deliver this type of care and really show how it can be done. It's exciting.
All right. Fantastic. So it's been a great discussion. And what I'd like to do is just close out with a vision for the future. So I continue to believe that the traditional independent primary care model practice is obsolete. I think that we've already seen, let's say in a market like New York, a vast majority of primary care docs have moved to employed kind of arrangements, usually with a health system. And really the only docs who are still doing primary care who are on their own are doing concierge and have a price point that makes it make sense. But I think that even at the health system level, I don't think large academic medical centers do primary care well, because primary care is basically a loss leader to get to the high margin product of the specialty care or tertiary care or quaternary care. So my question is this massive aerial assault that we're seeing from venture-backed and publicly traded primary care companies, is that going to change the market from a measurable market share perspective? In 10 years, can we say that 50% of Americans will get their care from an Iora, One Medical, VillageMD, Oak Street? Do we think that 50% number is high, or is it low? And by the way, I'm a One Medical customer, so I'm already counted in the numerator there. But just some predictions for the future. 10-year timeline, 50% is the hurdle rate. Am I high or am I low?
So I'll say this. I could not be more bullish on the VillageMD model and the models of my peers. I think we're kidding ourselves. We think we're going to get to 50% in 10 years. There's a reality, which is that the health systems today are generating hundreds of billions of dollars of margin, and they're going to hold on to their machines for as long as they possibly can. And there's also a reality, which is that every one of these models that we're introducing is different, and it's hard. Right? Like no one here would say this is super easy, because at the end of the day, whether we're recruiting a brand new physician or recruiting someone who's got 20 years of experience, there's a change in the way that they have to do things that we have to acknowledge. And if we systematically, as a cohort, as a group, if we try to scale too fast, we're going to screw it up. And that's just a reality of the world that we all live in. So each one of us is sort of building components of scale and to go fast and fast and fast. But, if I just look at what we've committed to do 600 new clinics in partnership with Walgreens over the span of the next 5 years, right? It's just simple math around that means that for every Tuesday and Thursday for the next 5 years, we're opening up a new clinic. We've got to do each one of them incredibly well. We're already scaling at a pace that's faster than what Starbucks did when they were 30 years into their journey as a company. And I think that, opening up a clinic with physicians is a little harder than opening up a store with baristas. So I think there's a reality, which is that I think each one of these models is going to be massively successful. But at 50% market share, I'm not sure that's a reality.
But I think the thing that will change is actually consumers voting with their feet. So pointing at Robin, consumers do not like the current model. And I think, yes, these health systems and yes, the established providers will try to hold on to things. But in the end, the thing that moves markets, the bet we're making is that, I think value-based care is a red herring. The thing that we are all doing on this call is providing a completely different consumer experience. Actually addressing the things that they want to be experienced, feeling like crap. I loved your acronym there, right? Just feeling like crap. We're doing that, and we're giving them health coaches, and we're giving them transportation, and we've got appealing ways for them to interact with us. And we do it by email and text. And in the end, that will drive this market.
I agree with that clearly, or maybe not clearly, but I think that also, a lot of the sexy things happening are in the MA space, treating this sort of particular population right now. But there's a whole slew of generations coming that have very different expectations of what their healthcare experience look and feel like. are used to paying out of pocket or used to interacting with technology differently are facing a different set of conditions and also a different set of expectations around how they feel. And I think that what I hope at least is that we've talked a lot about the doctor and as the sort of hero of the story. And historically, the doctor is the hero of the story, right? The person in the cape or like the white knight in shining armor or whatever it is. And I hope we're moving to a place where the patient's the hero of the story, where they're able to manage their own journey. They're able to flex in and out of the types of services that they need. They're given more choice, but also education and empowerment around what they experience. Tim's right. Will we clear the 50% mark by that definition? Probably not. But I think a lot of things are going to shift and change in this time horizon around the way that healthcare is delivered, even when it's still delivered by some of the traditional players in the space.
I would add to that I think, what I would see as a reasonable goal by 2030, let's call it 10 years, is that we can reach that tipping point where we've kind of crossed the chasm, right? There's enough of these models. And, to Robin's point, I think Medicare Advantage has led the way. I'd love to see commercial advantage kind of catch us up, the stuff that Robin and I are trying to do, that more people from that commercial sector can jump into these models. But getting to that tipping point and then hitting the fast part of the adoption curve would be wonderful. And I think our country really needs it.
All right. And with that, I love ending on a hopeful theme. It feels like we're moving in the right direction. So I wanted to say, Tim, Scott, Rushika, and Robin, thank you very much for joining me today. I know you guys are busy building big businesses. Tim, hearing you launch 2 clinics a week, that is amazing, and hopefully can make the difference in the lives of many, many people. And I hope to meet you all at some point in the future when this whole pandemic thing is over, and hope that you all have safe travels and you stay well. All right. And with that, I think we're done for the day. Thank you very much.
Thank you.
Thanks, Jean-Luc.